Welcome everyone. This is Dr. Jaitly, your cardiologist from New York. Welcome to the MuniMeterHealth. That's your video site, which is now on several social platforms, media, primarily to encourage you to participate in our educational programs per video vignettes. Obviously, we are doing this to enhance the education in the medical fraternity, but also in the patients at large, so this way we can have a better clinical outcome, because obviously if patients know about their tests, know about their illnesses, know about their therapeutic options, I think the doctors will be able to enhance their clinical outcomes much, much better. And that's what my global initiative and then the deepest belief is. So welcome again to MuniMeterHealth, your favorite video site on several social platforms. Without any further ado, it's a very short video vignette again, where I'm going to be talking to you about briefly what is cardio-oncology. Now, this is a new field, relatively, and of course, it's been known for almost 20, 30 years, when actually I was doing some research over at Texas Heart Institute, and then subsequently waiting for a fellowship position at Cornell in mid-80s. That's where I think the earliest exposure I had to Adriamycin. So it's been around for a long time, this Adriamycin, for almost like 30, 35 years now. But it's a wonder drug in cancer and oncology world, obviously. Lots of oncologists are using this for several cancers. But again, within the scope of this video, we're not going to talk much about oncology. We're trying to see how best oncology drugs or chemotherapy drugs, they're impacting on the heart, and chiefly the left ventricle here, which is now getting compromised because of chronic use of Adriamycin, or during the acute use as well. So anyway, Adriamycin, anthracyclines, these are supposed to be known cardiotoxic agents, and the very fact that many oncologists unfortunately do not refer them to the cardiologist prior as well as during and after of the chemotherapy, sometimes I begin to wonder that they may be, some of these cases may be falling through the cracks, and one may not know the exact number as to where and how many patients have cardiac problems or cardiomyopathy, as we discuss. So this is one of the issues, I think, where cardio-oncology field now is relatively new and it's developing. And but anyway, the cutoff dose for Adriamycin is about 450 milligrams per meter square, but does not mean that you can continue doing this until you reach that dose. So the whole idea is wanting to know what the baseline LVEF first is, and say if it is more than 55% in that individual, in that say lady being treated for breast cancer, etc. So now, if the ejection fraction is more than 55%, the cutoff is that if it drops to 50 or less, obviously, or if the drop is more than 5% in the EF, then that really gives a real what you may call a reconsideration option for the treating oncologist, whether to go further with the chemotherapy or to consider lowering the dose, lowering the peak dose, or even stop it. DC it, discontinue it. So these are some of the options that the oncologists can make their own decisions regarding, and it's a balance between whether or not you want to treat the cancer with the fullest dose, but then at the same time at the expense of compromising on the left ventricle here. So that's an issue. We know it's a cardiotoxic agent, but the fact is that you certainly want to, the goal from the oncologist point of view, I can understand, is to try and render the patient cancer free, but not at the expense of. And we as a cardiologist, this is where we come into our pictures, and we say, look, not at the expense of compromising on the ejection fractions, because eventually what will happen is these patients ultimately will become cancer-free, but at the same time, then they are cardiac survivors. So I call them cancer-free heart failure survivors, if you will. And again, the mortality can be more than 50% in these patients who drop their ejection fractions. But the good news is a lot of this heart failure, we call it CHF, is reversible, and that's the good part. But it has to be checked in much earlier stages. And how do you do that? Well, there are imagings that one can resort to. One is an echo imaging. Second is a MUGA, which is a nuclear, obviously. That's a nuclear technique. and it's a very, very simple technique. It's almost like takes about roughly an hour, and you're out of the hospital or whichever center is doing the echo or the MUGA. Very rarely now it's done as a right ventricular biopsy. I remember in 1980s, the first one of the first papers where I was actually part of the research was published in the annals, and turns out that right ventricular biopsy was being compared with the echo, and that at that point we did not have the Doppler. All we had was the left ventricular ejection fraction and a MUGA scan. A cardiac MR is now more preferable, and then of course in the echo, remember the strain pattern is evolving where patients can be very early on detected, because the whole idea is wanting to see if we can prevent. Remember, prevention is better, right? So prevent the onset of heart failure. If you can prevent the onset of heart failure, that is the key. It's not that once the heart failure sets in, that's when you consult a cardiologist. You really want to see if you can prevent the onset of heart failure. And how do you do that? You get a baseline LVEF, look at the strain patterns, and then identify those patients who are prone to develop. Again, cardiovascular risk factors will have to be evaluated in all patients. No question. If these patients are hypertensive, they already have an asymptomatic LV dysfunction, for instance, or they have an ongoing other risk factors like chronic smoking or coronary artery disease, for instance, is already existing in these patients, or sometimes just LVEF is down, and the patients are asymptomatic at this point. So asymptomatic LV dysfunction is one of the issues which I think should be really pointed out very well, because a lot of the times patients can be detected very early on just based on a quick echo or a MUGA scan or even a cardiac MR. All right, so just remember, imaging has a huge role. Cardio-Oncology is a developing field. Adriamycin and anthracyclines are the groups of the drugs. There is a monoclonal antibody which is now being treated, which is now being applied for the treatment for breast cancer as part of the chemotherapy, and that's it's a tongue twister here, trastuzumab, and this drug really is also shown to be, again, cardiotoxic. And then there are Vsp inhibitors. We call them VEGF targeting inhibitors, and these Vsp inhibitors they are being used for the kidney cancers as the oncologists prescribe them. But the fact is that they are also they're also non-angiogenic, and as a result that they can impact on the left ventricular ejection fraction. As a result, the LV tends to dilate, and these patients develop CHF. So remember that these patients are prone for cardiomyopathy, but many times it's very early on. It could be reversed. The dose has to be reevaluated as you go through the chemotherapy cycles, and a baseline and during the interim, as well as follow-up EFs are required. So it's always nice that the oncologist really consult with the cardiologist all the time. So this way we have a concomitant care that's being offered through our interconsultations, and as a result the patients benefit and the clinical outcomes are the best. Okay, but thank you again for watching us on MuniMeterHealth. Again, this is a purely an educational site. It's not a treatment plan. It's not an medical advice we are offering, but mainly a medical education site, and it's a supplement to a syllabus that the students like to follow. So this way they can add on in a quick 5 to 7 minutes of our video vignettes that I present. Okay, thanks again. So long. See you again at MuniMeter.